Hello everyone, today our topic of discussion is second degree atrioventricular block. Here in this lecture we will discuss about the types, sign and symptoms, etiologies, prognosis of the second degree AV block, differential diagnosis, investigations, management and some clinical cases. First of all, second degree AV block has two types, Morbid's type 1 which is also known as Winky Bank and Morbid's type 2. So in this conduction can be delay in AV node or in the His bundle. Conduction can be delayed or blocked. If the conduction is delayed, then it will prolong the PR interval. If it blocked, then there will be misbeat. Now sign and symptoms in the second degree AV block can be asymptomatic, especially the Morbid's type 1 can be asymptomatic. Then there will be the lightheadedness, dizziness and syncope, especially in type 2 Morbid's type 2 there will be the syncope, dizziness and lightheadedness. Then there also can be the chest pain in case of myocardial infarction or ischemia. For example, in acute myocardial infarction, especially in inferior wall MI, there can be the heart blocks, can be first degree, second degree and even third degree heart block, as there is the AV node involvement. So in that case there will be the chest pain. Then the beat, if we talk about the pulse or beat, will be the regularly irregular heartbeat. It's mean that there will be the equal uh, pulses. Then there is the draw beats, regularly irregular. Three beats will be consecutive, then there will be the draw beat, then there will be again three beats, then draw beat. Then there can also be the bradycardia, heart rate less than 60, hypotension or hypoperfusion. Then we now discuss about the different etiologies. The etiologies can include drugs. In drugs, digoxin, as we know, digoxin has two mechanisms. One is the sodium potassium channel blocker and second is the vagal stimulation. In case of vagal stimulation, it can prolong the refractory period of AV node and can cause heart blocks. It can be heart block can be the first degree, second degree or even can third degree. Then there is the beta blockers. Beta blocker also increase the PR interval or refractory period of the AV node, which can lead to the heart blocks. Then there are the calcium channel blockers, especially verapamil and diltiazem, can increase the refractiveness of the AV node and can cause heart blocks. Then there are the certain antiarrhythmic drugs, especially uh, sodium channel blockers, which include 1A, class 1A and 1B. Then there is the class 2, which is the beta blocker, class 3, which is the include the amiodarone, butylide. Then there is the class 4, which is the calcium channel blocker, and other drugs which include fingolimod. This is an immunomodulator drug and used in the multiple sclerosis. This can also cause the heart blocks. Then there is the adenosine, which is used in the supraventricular tachycardia, can cause heart block. Then lithium, used in the bipolar disorder, can cause heart block. Benzathine penicillin, which is used in the rheumatic heart disease. Clonidine is the alpha 2 agonist. It can cause second degree heart block. Then there are some inflammatory diseases like endocarditis, infective endocarditis, myocarditis, which can be viral diseases or other autoimmune diseases. Lyme disease is caused by Borrelia burgdorferi, acute rheumatic fever. These diseases can cause inflammation of the conduction system of the heart or damage to the conduction system, or which lead to the heart blocks. There can be first degree, second degree or third degree, and in these diseases such as Lyme disease, it can be reversible if we treat the disease. Then there are inflammatory diseases, amyloidosis, hemochromatosis, and sarcoidosis. These diseases can cause cardiomyopathies and as well as heart blocks. Then there are infiltrative malignancies, which include Hodgkin lymphoma and other lymphomas like multiple sclerosis. In multiple sclerosis, there can be the amyloidosis and calcium overload, which can lead to the conduction heart blocks problems. Other disorders like metabolic and endocrine disorders, hyperkalemia can cause the atrioventricular blocks. Then there is the hypermagnesemia, Addison disease, which is the adrenal insufficiency and can lead to the hyperkalemia. Then there is the hypothyroidism, myxedema, which is the severe hypothyroidism. Then other disorders are collagen vascular disorders. Heart blocks can also be associated with ankylosing spondylitis. In there is the bumbo spine and spine problems, joint problems. Dermo dermatomyositis, which is the autoimmune disorder involving the skin and the muscles. Then is the rheumatoid arthritis, disease of the joints, which is an autoimmune disorder. Scleroderma, and as systemic lupus erythematosus, which are also autoimmune disorders. Ritter syndrome, which is autoimmune disorder mostly after the infections like Shigella and Salmonella, which can lead to arthritis, urethritis, and conjunctivitis. Then there is the mixed connective tissues. These different disorders can lead to the uh, heart blocks. Then the other disorders are cardiac tumors, trauma during the catheter based procedure and the surgeries of the heart can lead to the uh, damage to the his bundle or other conduction system and can lead to the heart blocks. Then is the valvular heart diseases, especially the aortic stenosis and the aortic valve replacement. As the site aortic valve or annulus of the aortic valve is near to the his bundle, and the damage to the aortic valve or replacement of the aortic valve can lead to the heart blocks. It can be first degree, second or third degree. Then there is the obstructive sleep apnea, then muscular dystrophies like Duchenne muscular dystrophies or myotonic muscular dystrophies, acute ethanol poisoning, and acute myocardial infarction, especially the inferior valve MI, can lead to the heart blocks. Then there is the genetic factors, for example, long QT syndrome and the Brugada syndrome, which are the ion channelopathy and can cause heart blocks. Then there is the we discuss about the prognosis of the second degree heart block, and the level of the block determines the prognosis. It means that if the block is in the AV node, then the prognosis will be the better, and if it is the inferior to the AV node, infranodal, present in the his bundle or Purkinje system, the prognosis will be the poor. For example, in AV nodal block, whether is the type 1 or type 2, carry favorable prognosis, whereas if it is AV nodal block, then if it is the infranodal block, and it can lead to the third degree heart block or complete heart block, and this it has poor prognosis. Then there is the Morbid's type 1 block. During acute MI, increase mortality. In case myocardial infarction can lead to the increased mortality, but in case of myocardial infarction, the heart block can be the temporarily, and it can resolve on its own. But in case of permanent degree heart blocks or symptomatic heart block, we do the treatment. Pombis type to carry the progressive to complete degree heart block. It can say second degree heart block has more chances to progress to the complete degree heart block as compared to the Morbis type 1, and increase risk of mortality. And the heart blocks, especially the Morbis type 2, can produce the Stokes Adams syncopal attacks. Stokes Adams syndrome is associated with the recurrent syncope attacks, which can be due to the poor cardiac output. It may be due to the myocardial infarction, or maybe due to the severe bradycardia, or maybe due to the second degree heart blocks. Then we will move to the diagnosis. In diagnosis, the diagnosis can be made on ECG, and the ECG will show the presence or the type of the degree block. Now, findings in the Morbis type 1 ECG. The most common type is the Mobius type 1. In this ECG, the gradually progressive PR interval prolongation, and then there is the blockage. Here you see that the PR interval in this ECG, PR interval is continuously increasing, and then there is the drop beat. So the beat is dropped and P wave is not followed by the QRS complex. Here there is no QRS complex, but other P wave is followed by QRS complex. In some cases, junctional escape beats may occur along with non-conductive P waves, but there is only few cases. Then the other point is the post-block PR interval shortening remains the cornerstone of the diagnosis of the Mobius type 1, regardless of the whether the periodicity has typical or atypical values. I will show you this in the next ECG. Here in this ECG, the PR interval is continuously prolonging from 1 to 4. PR is continuously increasing from this to this. The PR interval after the block, here is the block, the PR interval after the block is again decreased, shortened. So the PR interval after the block is shortened and before the block is prolonged. This is the very important diagnostic point for the Morbid's type 1 and cornerstone for the diagnosis. Then other findings which can be present in the Morbid's type 1 are the in as the PR interval is prolonging, the RR interval will decrease. What does it mean? It means the duration between the R of the 3 and 4 is less than as compared to 1 and 2, and this decrease is little, not so long, but it's so as the PR interval prolong, the RR interval between the beats will decrease. Then in the Mobius type 1, there will be the segment which include the missed beat. The RR interval between the missed beat is less than the two cycles. Here are the two cycles. The distance between these cycles is greater than the missed segment. So here is the 6 big boxes and here is the 7 boxes. In case of but in case of Mobius type 2, the distance between the missed period segment and the two cycles is are equal to each other. Other things are the RN interval. RN interval shortens as the PR interval prolongs, as we discussed in the ECG. There is the variable RN intervals with the pattern, then and the irregular heart rate. A pause occurs after the block P wave that is less than the sum of two beats before the block, as we discussed in the ECG. Now ECG findings in the Mobius type 2. There is the consecutively conducting beats with the same PR interval. In Mobius type 2 ECG, the RR interval will remain the same, and then there will be the blocked P wave. The RR interval remains same before and after the block, but in case of Mobius type 1, there will be the difference between the PR interval before the block and after the block. Here in the PR interval are equal, then there is the blocked P wave. The pause in compressing the blocked P wave is equal to exactly the sinus cycle of the length. This will I will show you this in the next ECG. In ECG we will show that the PR interval are equal in all these. Then there is the blocked P wave. The PR interval remains the same. Then also there is the equal duration in the RR. There is no change between the RR duration. Then there is also another finding in Mobius type 2 that the missed beat interval duration between the RR is equal to the two cycles of the normal sinus rhythm. But in case of Mobis Taiwan, this segment is greater than this one. But in Mobis Taiwan 2, they are equal to each other. Now, determination of the location of the block. By looking at the ECG, we can be to some extent can be sure about the location of the block by looking at the QRS complex, whether it is prolonged or narrow or wide. In case of wide, it is most likely infranodal block, and in case of a narrow QRS complex, it is most likely present in the AV node. Then there is the autonomic manipulations, which include carotid sinus massage exercise may help distinguish between an AV nodal and an His Purkinje system block. Improvement in the degree of the block with the exercise strongly favors an AV nodal location, and conversely an increase in block with exercise that atropine more strongly favors an His Purkinje block compared with the exercise. Vagal maneuver have opposite effect on the AV block, exacerbating the AV nodal block and improving the infranodal block. So in this way, we can determine the location of block, and to confirm the location of the block, we do the electrophysiological testing, and the indications for that are the infranodal block at the Mobis Taiwan associated with wide QRS complex, which is also indicated in infranodal block in the absence of symptoms, and in case of presence of symptom, we also do that. Mobis Taiwan with the history of unexplained syncope attacks, and the patient with pseudo AV block, and those with premature concealed junctional depolarization, which may be cause of second or third degree AV block, we do the electrophysiological testing. Then there the patients with the second degree AV block whom another arrhythmia are also suspected, we do the electrophysiological indication. Other investigation which we do in the second degree AV block are include serum electrolyte, so we can see the level of the potassium, calcium, magnesium. Then there is the digoxin level. If patient is on digoxin, when we see the toxicity of the digoxin by its level. Cardio biomarkers in case of myocardial infarction. If patient is presented to us with acute MI and also with the degree blocks, then we do the cardiac biomarkers, which in troponin, trop, and myocarditis related labs, for example the autoimmune myocarditis causes SLE and other, and the Lyme disease, and we also do the test. As we discussed the conditions in the etiologies, all conditions can be excluded out by testing if we suspecting them. Then there is the thyroid function test. Now we will discuss the differential diagnosis of the second degree heart block. It can diagnosis can be congenital heart block, sinoatrial exit block. What is the sinoaxial exit block? In sinoatrial exit block, the pulses are generated in the SA node, but the surrounding tissues sometime cannot transmit the pulse to the other tissues. So in the ECG, there will be the normal sinus rhythm continues, and in somewhere in the ECG, there will be the absence of a single beat. So in this we say that there will be the atrial exit block. The atrial tissue do not respond to the excitation of the SA node, and the beat is not transmitted to the remaining of the atrial tissue and the ventricles. So it was to some extent it looked like more heart blocks, so include in the differential diagnosis. Then there is the conducted premature atrial contraction. In premature atrial contractions, there is the ectopic excitation in the atrial tissues, which can there will be the SA node excitation, and there is the other ectopic excitation which can be conducted to the ventricles. Then differential diagnosis include in the first degree AV block, myocardial infarction, especially inferior wall MI can cause the heart block. Then is the third degree or complete heart block are included in the differential diagnosis. Now we will discuss management of the second degree atrioventricular block. The management of the first degree atrioventricular block In case of asymptomatic patient, there is no requirement any therapy, does not require any specific therapy in the pre-hospital setting or in the ER. In the asymptomatic patient, unless the patient is symptomatic, then we will give the treatment to the patient. Symptomatic patients or with MI, admission is indicated to a unit with telemetry monitoring and transcutaneous pacing capabilities. Patient with acute MI and second degree block are symptomatic patients with Mobius type 1 second degree block. We will have to do the transcutaneous pacing or transvenous pacemaker emplacement. Then the patient with the symptomatic patient should be treated with atropine and transvenous pacing until the further workup determines the etiology. The treatment with the atropine and transcutaneous pacing is temporarily, and the permanent treatment is the transvenous pacing. So the before given the atropine, there we should consider that this suspected, we cannot give in this suspected myocardial ischemic patient or patient with ventricular arrhythmia. We cannot give atropine to them because atropine can worsen the infranodal delay and increase the AV block. Management of Mobius type 2 second degree AV block: admit all the patients, whether it is they are the symptomatic or asymptomatic, with monitor beds, transcutaneous and transvenous pacing capabilities available. Transcutaneous pacing pads should be applied to all the patients with Mobius type 2, including those who are asymptomatic, because such patients has propensity to progress to the complete heart block. Transcutaneous pacing should be tested to ensure capture. If capture is not able to achieved, we will discuss what is meant by capture, and then insertion of transvenous pacemaker is indicated even in asymptomatic patients. We do the X-ray to confirm the position of the wire and exclude the complications related to the transvenous pacemaker. So here are guidelines for pacemaker implantation. The American Heart Association, American College of Cardiology, and Heart Rhythm Society gives guidelines related to the pacemaker implantation. The core of the recommendations for permanent pacemaker implantation is based on the two factors. One factor is the presence of symptoms related to the rhythm disorder, and second is the presence of an presence of infranodal block. It means the patient with the second degree block, Mobius type 1, if it is not symptomatic, if it is or asymptomatic, we do not insert the permanent pacemaker. But it if in Mobius type 1 infranodal AV block is present, we do the permanent pacemaker implantation or the symptomatic patients. In case of Mobius type 2, whether it is asymptomatic or it is symptomatic, we do the permanent pacemaker implantation. Indications are the second degree AV block associated with signs such as bradycardia, heart failure, asystole greater than the 3 seconds, 3 equal greater than or equal to 3 seconds. Second degree AV block with neuromuscular disorders, for example Duchenne muscular dystrophies or myotonic muscular dystrophies, there is the risk of progression to the higher blocks, and the progression is unpredictable in these patients. Then the Mobius type 2 with the white coalescent complex, most likely showing the infranodal block. The patients asymptomatic patients of Mobius type 1 with infra or intrahis bundle branch on the electrophysiological study. As we earlier discussed that in MI, the second degree block or third degree block can be the temporarily. If the block persists and symptomatic, then we do the permanent pacemaker implantation in these patients, especially with the bundle branch block. Here is some picture showing the transcutaneous pacemaker. These are the transcutaneous pacemaker pads. These are different pads than the ECG pads. We apply on the skin, and this is the monitor for the pacemaker implantation. Here is some pacing. We can change the rate from this monitor rhythm, and it will show the pacing on and off. And also we see here, we see the capture is present or not. Capture is actually showing the beat due to the pacemaker, and if capture is not present, we do the transvenous pacemaking. This monitor will help us to monitor the patient, either it will show capturing to on the pacing, uh, and other modalities to set the rate of the patient. For example, American Heart Association guidelines give us information that we should initiate heart from the 60, and then we move to the 70 or other rate. Here also some pictures showing the pacemaker implantation. Transvenous pacing from the left subclavian and right interjugular. This is the two probes in the right ventricle. And there is the dual chamber pacemaker implantation. Here is the in the right atrium. This is the right atrium, and it is the right ventricle. Then as we discussed earlier, that we can confirm the location of the pacemaker leads through the x-ray. In this there are, this is the device, and there are the probes going into the right atrium and also in the ventricles. At the end, we will discuss about the clinical cases related to the Morbid's type 1 heart block and the Morbid's type 2 heart block. First, we will discuss about the first scenario. An 80-year-old man is brought to the ER after syncopal episode. He has no chest pain or dyspnea but has severe constipation of recent onset. Was hospitalized 2 weeks ago for atrial fibrillation with a rapid ventricular response, and was discharged from the home with oral medications for the appropriate management. His past medical history is also very significant for the hypertension, for the COPD requiring oxygen therapy. His blood pressure is 105 over 60 mmFSD and pulse is 50 per minute. On examination reveals bilateral decreased breath sounds, no wheezing, and normal heart sounds. ECG show new onset second degree AV block. Which of the following is most likely cause of his current medication? Drugs include this. Now patient presents to us with syncopal episodes. The patient has a severe constipation from the recent onset, and on the previous admission to the hospital, patient 2 weeks ago, patient diagnosed with atrial fibrillation with rapid heart response. It means we discharge the patient on such medication which control the ventricular rate. It can in the atrial fibrillation, to control the ventricular rate rhythm, do the we give the medication like calcium channel blockers, beta blockers, in some cases digoxin and amiodarone. The most common drugs are the calcium channel blockers and the beta blockers. So patient may be given among these two groups of the drugs, and pass also patient is also has hypertensive and severe COPD. So, and also patient is symptomatic with hypertension, bradycardia, and bilateral decreased heart sound as patient is COPD. ECG show the second degree heart block. Now the drug which is causing the syncopal episode, the severe constipation, and bradycardia, we will choose one of these. Amiodarone cannot do the second degree heart block or cannot lead to the second degree heart block. Then there can be the indapamide is the thiazide diuretic. It can no effect on the heart. Then lidocaine is the sodium channel blocker. It does not affect to the AV node. Then is trazosine, which is the alpha 1 blocker, and it has no effect on the heart. Valsartan, which is the angiotensin receptor blocker, has no effect on the heart. We will choose one. It can be the propranolol or diltiazem drug which is prescribed to the patient. Then as patient is COPD, patient has this severe condition related to congestive pulmonary disease. So patient cannot be prescribed with the propranolol as it can worsen the condition of COPD. So patient most likely prescribed diltiazem, which show the patient has constipation and the second degree heart block. What will be the management in this case? The patient, as patient is symptomatic second degree heart block, we will do the pacing, initially the transcutaneous pacing and later on the permanent transvenous pacing. And now we will move to the second our scenario. A 44-year-old man comes to the physician for routine health maintenance examination. He feels well. He underwent appendectomy at the age of 25 years. He has history of hypercholesterolemia that is well controlled with atorvastatin. He is an avid marathon runner and runs 8 miles per day 4 times a week. His father died of MI at the age of 42 years. Cardiopulmonary examination shows no abnormalities. His abdomen is soft and non-tender with a surgical scar in the right lower quadrant. Lab studies are within normal limits and ECG is shown. And which of the following is the most likely diagnosis? Now, patient is young, presented with this, come to the hospital with routine maintenance health examination. Patient has history of hypercholesterolemia that is well controlled. Patient is marathon runner and runs 8 mile a week and also has the history of myocardial infarction in the early ages. Then the findings, now we will see the findings on the ECG. As in the ECG there is the regularly regular RR intervals, then there is the drop beat. So the pulse is regularly irregular. Then there is the prolonged continuously PR in prolonged PR interval and after the block. So the on ECG findings it is a Mobitz type 1 block. Mobitz type 1 block, as there is the continuous increase in the PR interval, then the drop beat, and also the post block PR interval is shortened and pre block interval is prolonged, which is the typical findings in the Mobitz type 1 block. Uh, uh, the other options which include MI, it cannot be MI as there is no ST elevation. Third degree heavy block, as P is followed by QRS complex and there is no dissociation between the P and QRS complex, so it cannot be the third degree heart block. Then there is Mobitz type 2. In Mobitz type 2 there is the uh, equal P, all the PR intervals, and then there is the drop beat. And also in the second degree Mobitz type 2 block, there will not the post block shortening of the PR interval. Then there is the first degree heart block, there is the no mix beat in the first degree heart block. In first degree there is only prolonged and similar equal prolonged and equal PR interval in all the QRS complexes. Now clinical case related to the Mobitz type 2. A 78-year-old man is brought to the ER because of the fatigue and lightheadedness. He does not have chest pain, palpitation, or difficulty breathing. He has history of hyperlipidemia, type 2 diabetes, mellitus, hypertension, osteoarthritis, asthma. Current medications include simvastatin, metformin, lisinopril, albuterol, ibuprofen. His pulse is 48 per minute and blood pressure is 89/50. He responds slowly to the questions but is oriented to person, place, and time. Examination shows dry mucous membrane. His lungs are clear to auscultation and vowel sounds are positive with no pulsatile masses or bruits. Pedal pulses are non-palpable and dyslexemics are cold. Capillary refill time is 4 seconds. Anesthesia shows left axis deviation and Q wave in the lead 3. A constant PR interval of 0.15 second. with every third p wave that is non-conducting and QRS complex interval of 0.09 second. Which of the following is most appropriate next step in the management? First, we do the diagnosis, then we will see what will be the management in this case. Patient presents to us patient presents to us with fatigue and lightheadedness. Then patient not respond to questions. Patient is mildly confused. Then there is the bradycardia, 48 per minute. Then hypertension. So patient presented to us with the symptoms, and we say the hemodynamically unstable patient. And there is also the dry mucous membrane and increased capillary fill time and non-palpable extremities showing the hypertension and hypoperfusion. And ECG, in the ECG there is the left axis deviation and Q wave in the lead 3. uh, Q wave are finding in the single lead are mostly non-significant. The constant PR interval of 0.15 second, which is the normal uh, interval, as the normal PR interval is between the uh, 3 to 5 small boxes, and this is less than 200 milliseconds or zero point 0.2. Then it also mentioned that QRS complex is interval of 0.09 seconds, which is also normal because the normal QRS complex is 2 to 3 small boxes, which is zero point 0.8 to zero point 0.12, which and it lie in the normal. Then he said to us that every third P wave that is non-conducting. It means that there is the P wave, there is the QRS complexes, then there is again P wave, then there is the QRS complexes, then the third P wave, and there is the pause, then P wave and this one. This P second and third P. He said to us that the PR interval is constant. All the PR intervals, he said to us, but I cannot make like that. All the PR intervals are constant and every third beat is non-conducting. It means that patient, our diagnosis is morbid type 2 block, and also patient is symptomatic and heart rate is 48. So what we will do we either we do the dopamine, we cannot give the dopamine, we cannot give the glucagon. Dobutamine increase the heart rate and we will not do also do that. Norepinephrine will not be nothing to do with that. Epinephrine will not do that. We do the cardiac pacing, temporarily transcutaneous cardiac pacing, and then permanent pacemaker will be applied to this patient. Here our topic of today ends.